The next thing we're going to talk about is sort of very much disease-based, and we're going to talk about communicable versus non-communicable diseases. And one of the things to think about is that when a country, wherever they are in their sort of terms of development or resources, people who live in countries with lower access to resources, less resource places, are more likely to die or be impacted by what we call communicable diseases. And what those are diseases that you can easily spread to the entire population. They are usually caused by things like organisms, bacteria, viruses, or parasites. They have been one of the leading causes of death and disability. They also impact the very young and the very old. They usually cause great epidemics that wipe out lots of people in the population. And they can often be a routine reason for people to die. So things like malaria, HIV/AIDS, polio, measles, those kinds of things have long been communicable diseases. We're sort of looking at, when we look at them, we're sort of looking at factors that lead to these things, right? So it's TB is also part of that, tuberculosis. We're looking at how they're transmitted when we're trying to figure out what we can do with them, and what period are they communicable. So some diseases, like measles, we talked about previously, if I cough, it's transmittable for a long time, and it can stay to be infectious, right? We want to look at how that's happening, when it's happening. When we look at HIV/AIDS, we know the ways it's transmitted. We also know that there are different interventions that we want to do based on where it's transmitted. So from mother to child, we've come up with medication that has, if delivered in the correct way and the right time, can reduce that to almost a zero transmission level, which is great because then that means infants are not getting the transmission of the disease. One of the things you do need to look at is when you're addressing that is what are the barriers or isolations that we can put up. So like with malaria, bed nets have been very impactful. People with HIV/AIDS, you could do abstinence. Could we have cleaner water? So then we would have less incidences of cholera because that is impacted by water. What are there things like immunization? So measles, mumps, rubella, polio, those are all immunizations that we can do that would reduce the impact, that those diseases wouldn't come and be the number one killer of children in most places. We can also look at what's the time for screening them and finding new cases. One of the things that we're trying to do now is have a more transportable way to screen for malaria, because if we know if someone has malaria, then we can also deliver them drugs in a more impactful way, especially with very young children. This is very difficult though, because the places where malaria happens the most are places that are kind of remote, and there's not necessarily lots of technical equipment there, sometimes not even access to reliable electricity. So sort of running a centrifuge to do a test is a non-starter. So we need to come up with ways to do that. One of the things we have to look at too is what are the treatments and how can we get them? So again, if we're talking about immunizations, you and I, we go to the doctor, we get them, it's great. Again, not a lot of electricity, not a lot of refrigeration. So if I'm trying to get immunizations to certain places like war zones or places that are very mountainous without access to electricity, somewhere like Afghanistan, I'm going to have to produce what's called the cold chain, which means I have to keep the immunizations at a certain temperature for a very long time. So I have to make sure that that temperature maintains itself, or else they're unimpactful. So you have to sort of build up an infrastructure in order to deliver the intervention that's most impactful. Another thing you have to keep in mind is sometimes, and we saw this with HIV/AIDS, is that we came up with these drugs in the West, and that's great because we have governments that can pay for them, and the drug companies made them because we have governments that will pay for them, but then we're going to take it to places. One place was South Africa that had one of the highest incidences rates, and we were looking at possibly people from the ages of 18 to 45 all being impacted or dying from HIV/AIDS, which means there would be no economic productivity. There would be children and grandparents left. Both populations cannot work to enliven the economy. So we decided that we were going to try to deliver medicines there. Well, the problem is the cost. It was $10,000 a year. They didn't have a well-developed at the time public health system. There wasn't health insurance, and it was just coming out of apartheid. So economic development, and it still has high unemployment currently, wasn't there, so we couldn't actually have them pay for that. So how do we make sure they get access to the drugs that we know work, that save lives, in a timely way that they can afford them and get to them. And then we have to make sure if places, not so much South Africa, but other places where we were delivering drugs, there's not a healthcare infrastructure there. So how do we do things like make sure that they stay on their medicines? Because if they don't, then the virus mutates and it becomes worse. How do we make sure that there are healthcare workers who can educate them, check their blood, make sure that they're okay, make sure that they're getting enough food, because you have to have food at a certain time to take these medications, making sure that they're reducing risks for themselves and others. All of this kind of information and all this infrastructure also has to be built up. It's not just enough to provide them medicine. And I think one of the things we forget in more researched communities is that we already have all this in place, and that sort of makes this smoother, not perfect. We still have people who don't have access to life-saving drugs, but it makes it smoother, and we have more resources in order to get that to individuals. You can't just transfer what we have somewhere else and expect that there's the money and the healthcare infrastructure and the resources, both in personal capital with doctors and nurses and healthcare workers, to provide these life-saving drugs. Same with immunizations. We can't assume that there's places to store all of this so that we can just deliver it. A lot of places where there's not immunization, we're remote. How do we get people there? How do we make sure they're safe? All of those kinds of issues you have to think about, especially when you're trying to reduce communicable diseases, because isolated places communicable diseases are going to spread very quickly and impact a whole population. So now let's go to the diseases of more developed, more resourced places. And it's almost like a continuum, right? So places that we've seen, we've sort of helped tackle the communicable diseases, and the next thing we see are the non-communicable diseases. And what are they? They're sort of like diseases of lifestyle. So they're things like hypertension, diabetes, heart disease, depression, which is the #1 world disease that has impacted people's life capacity. All of those things are chronic debilitating illnesses which are due to non-communicable diseases. So if I have a disease like hypertension, I'm not going to give it to you in the same way that if I had measles and you weren't immunized, I could give it to you. So it's cardiovascular disease, Alzheimer's, cancers, all those kinds of things are things because people are living longer. Diabetes because they have access to less healthy food. They might have more stress, less physical activity. So again, on that continuum, the United States is very much experiencing these non-communicable diseases. Now, they don't kill people right away. They take a long time to kill people. It's very expensive, right? Because you have to treat them all along. It does mean that they are not able to be as productive as they would like to be. If the non-communicable diseases hit people in the middle of their life or early in their life, then the negative impact is spread out throughout their life. Mental health conditions are the #1 reason for morbidity and disability in the world. So it's not just physical, but it's also mental health issues, depression being #1. And one of the things we have to think about is when we talk about this, it's not an immunization that's going to fix this, right? It's what kind of impact, what kind of screening tool do we have to see if people who are most at risk. So it's one of the reasons why we now have, with children, we test for cholesterol and their risk for that. We also test for things like cancers to see if they're there, because the earlier we get to them, the more treatment we can produce. We also test for things that will allow us to reduce the death and the disability from them. So early detection is really important, but we also have to be able to do something with that screening tool. So it's not enough just to test you and go, yep, you've got it. We also have to make sure, because that is the social responsibility that public health officials and health officials have, that if we test you for something, that we then are able to provide you with the intervention that is most impactful. It is not enough to say, yes, you have this. We also have to make sure that you have access to cancer treatment if it's cancer. If you are testing pre-diabetic, we then have a responsibility to make sure that you have an intervention that you can actually carry out no matter where you are, no matter what social factors are impacting you or leading to this. And that's where it gets very difficult and very expensive. So communicable diseases are expensive because they wipe out people in the prime of their life, but they wipe them out. Non-communicable diseases are sort of long-term costs. They require not just a vaccine or a simple drug or changing the water system a little or cleaning up the infrastructure. It requires a whole bunch of factors to work together. It requires an intervention from a whole lot of components, and that's why they're more expensive and often more difficult to treat. We have to look at who and what we pay attention to. So we have to look at what if we invest what money, what will we get for an impact? So if we make sure that everybody has access to certain drugs for hypertension, that means we're going to have less strokes, we're going to have less types of cancer. If we make sure that everyone has a healthier lifestyle, physical activity, healthier access to foods, and that they can be more physically active, then we're also reducing the diabetes, right? Instead, what we're seeing is the reverse, which is not what we want. But that's the kind of issues that we have to deal with when we're talking about non-communicable diseases versus communicable diseases. They have different kinds of impacts. They have different kinds of reasons we screen. They have different types of systems that we need in place to treat them, right? The one, communicable diseases, we need somebody to deliver the medicine and monitor. For the non-communicable diseases, we need long-term interventions. We also can have a direct impact, not with just an immunization, but with changing lifestyles, with changing the trajectory of someone getting it and where they go with that disease. It requires different policies. It requires different ways of thinking about public health. And again, we sort of see this continuum. The longer countries are, the more resource rich they get, the more likely we are to get to non-communicable diseases.